Going to finish it up with our last session, which will be hip and femur fracture management. Our session moderator is going to be Dr. Nwachuku. A veteran of this conference. See it? Dr. Graf's going to stay up here. Another veteran, Dr. Susan Harding, formerly of Hahnemann, and Dr. Mitesh Shah, also formerly of Hahnemann, currently at Lankenau Medical Center. And Dr. Matt Craig, Rothman Institute at Abington. All right, guys. Hey, take it home. Let's go.
Good afternoon, good evening, good morning, everybody. First and foremost, Sakib, great program again. So appreciate it. It's always good to actually come back and see people that have been part of your training at some point in your life and actually get to see some friends that you haven't seen in a while. So again, glad to be here with this panel. Respect everybody that's on this panel, so hopefully they can help me out with some of the issues I have with taking care of these geriatric patients. We have today Matt Craig with us, Dr. Ken Graf, Dr. Susan Harding, and also Dr. Mitesh Shah. I'm Chinenye Nwachuku. I'm one of the orthopedic trauma surgeons at St. Luke's and currently at Easton area. We get a lot of geriatric trauma where I am, so I figured today I'm going to ask my panelists to kind of help me out, figure out how to actually correctly diagnose some of the injuries I'm going to present, what the options they utilize to actually get these patients the best outcomes, and basically give us some tricks as far as how to get out of trouble when we're in the operating room. The main thing when we talk about periprosthetic fractures, I'm going to just put it out there, that's what we're going to talk about for at least a couple of these cases. Main thing is we got to get them mobilized. So in saying that, we have a 65-year-old male community ambulator, history of bilateral toe knee arthroplasties 5 years prior, fell down a flight of steps. Otherwise, past medical history, he has AFib, but he's not on any kind of anticoagulants, which is great. Not the biggest guy in the world, BMI 21, but it's a closed injury, and this is what we got. I'll start with Mitesh just because Ken's been on the ball for the past 30 minutes. What do you see here, and is there anything else that you need from me?
Sure, yeah, it looks like comminuted supracondylar distal femur fracture right around that total knee. It doesn't look like there's no implants above it, but right here I'm probably looking to get a CT scan to get a better definition of those fracture fragments, how much bone's attached to that prosthesis. Looking at seeing that there's an open box to that prosthesis just to start thinking about treatment options and all that.
Okay. Susan, just real quick, do you get a CAT scan also for these right off the bat?
Yeah, I mean, I try to do some provisional reduction, get it out to length a little bit, just in the emergency room kind of thing. And, I don't usually, especially in the elderly, put them into skeletal traction just because their bone quality is poor. And a lot of times the pin is just problematic. But if you got residents or you got extra hands and you can kind of just get it out to length a little bit, even if it shortens, at least it's straighter, you get a better understanding of the fracture fragments and stuff like that when you do your CAT scan.
Are these residents, when they're calling you, are they giving you the classification and going through all that stuff to kind of help you out as far as like trying to present it to you, trying to better define it? Does the classification even mean anything to you?
Well, the catastrophe that is my professional career right now, I work in a place where I don't have residents. Awesome. So the ER doctors do not classify this fracture in any way, shape, or form.
Okay. Anybody that has residents, is that something that they kind of come to say, this person's a raw back or a SU or something like that? Do they still kind of present that way, or is kind of just presenting what they see?
I think I'm probably looking for a descriptive analysis of this fracture rather than a complication.
Yeah,
I mean, if one of those classification systems changed my management and helped me guide treatment, I'd buy into it, but I have yet to find that one.
Okay. I think this is a good point. I mean, there's so many classification systems for these periprosthetic distal femur fractures. But again, some of them look at the bone quality, some of them look if it's loosening, some of them even look into what type of implant was placed. But again, I don't think anything really defines gives us, okay, this is what you should do if this person has this type of injury. Because again, what we're trying to figure out is if there's any kind of loosening. But I got you that CAT scan, Mitesh. So there you have it. Usually I get a 3D recon if I can. I just can't see anything for CAT scans, depending on what kind of fracture it is. But Matt, anything?
So I like what Susan said. It's like the distal humerus, get a traction view, distal femur, you can get a traction view, you learn a lot from that. The CT scan tends to be there before I get there, so I'll look at it, but it doesn't change my management. Only very recently did I see a CT scan where I could tell that the implant had debonded from the bone. And my call to my colleague was, I don't know what it's supposed to look like, but I think that's what it looks like. And that's the first time in 15 years I've ever seen it. So that's what I'm looking for, a CT scan. Is this debonded? Is the implant debonded from the bone that's going to go on to distal femoral replacement? If this implant is stable to the bone, I'm going to fix the fracture. So I'm looking at a comminuted supracondylar distal femur fracture with what looks to me to be a stable implant.
Okay. Who gets this call? Is it the trauma guys that get this call every time this case comes in, Ken?
Yeah, it's whoever's on call that night, but it's usually a text with the X-ray on it.
Okay.
And actually, no, they usually let them sleep. They let you sleep. Yeah, that's Barker. He's one of our. They usually don't call you with this. You go over it in the morning.
Okay.
You know, unless it's
do you
going to
mean
come
is-
out of the skin.
Do you mean, are the joints guys getting this call? Is that what you're saying?
Any of them getting involved in this now?
No.
I call them.
Nah, not
They're sleeping.
They're sleeping?
Yeah.
Okay. So this came in on like a Thursday, so the trauma guy was on Friday, and this is what I ended up doing. Did a nail plate. Would anybody do the same thing? Would anybody do anything different? If so, just kind of critique it, chop it up, tell me what I did wrong or what I could do better.
I've had good success with these with just the nail. Nail looks a little small.
Okay.
But then again, it looks like you had an open box, so you should be able to get maybe an 11 to 12 millimeter down there. Probably I would stop it at 11. I just don't have a lot of experience with doing nail plate. I will if I have to, but I've got good fixation with some good nails that are out there now, and just do the nail without the plate. I like the idea, though, that you want to, hopefully you're letting this patient waiver to tolerance immediately after your surgery.
Yeah, that's what I'd say. I mean, I'd probably do a construct like this with a nail plate, but I mean, Matt, if you're gonna do a retrograde nail, what are you letting him weight bear at?
Weight bear is tolerated.
As tolerated with the nail?
Yes,
Wow, you're braver than I am, man.
it's working.
So if you see medial comminution, you know, and that's one of the reasons why I kind of decided to plate it, just because I was worried about that medial side. Does that make a difference as far as like what you would do, man?
If it's very distal, this one looked okay to nail. If it's very distal, then I'm going to just, and think it's too distal, the air quote, too distal to nail idea. I'd use a plate, and I've also dual plated them if necessary, plated both medial lateral sides, when you get these very osteopenic fractures and so forth.
Is there a certain number of interlocks that's too distal? Like what makes it too?
Maybe it's around the flange, I would say. I mean, this one's, the fracture seems to be all above the flange, and so the constructs are very distal. You can get either at the flange.
Yeah.
It's kind of a gestalt sort of idea, I guess. I don't use a number.
Yeah, this guy's only 66, right?
Yeah, 66.
Yeah, you said a community ambulator. Does he like walk with a walker, or does he like walk with a cane, or just walks like
Beforehand,
you
he
and
didn't
I,
walk with
just-
anything. He was
just
community
rolls.
ambulator, yeah. Just did his
Yeah,
thing.
this guy do fine with anything.
I hope so.
Yeah, looks good.
And they'll call you back when he needs his total hip.
There you go.
That's the only thing.
That's why I see that too.
So did you get cute and try to go screws through the plate through the nail? I
So-
can't tell.
That's the thing. You know, Susan, I know that you wanted to say something,
Yeah, go ahead, though. You go
but
first.
that's what I wanted to ask too. I don't go all the way to the top. I don't necessarily go and protect the neck, right? I don't know if that's the right thing, but again, I just feel like, you know what, if I'm putting something into the neck, is a stress riser right there. It could still fracture right there. Granted, it's not at the subtroch region where we always worry about when we do, you know, these cannulated screws, you know, but again, I don't know if it's warranted to go all the way to the top. Again, I don't know if that's the right or the wrong answer for this treatment plan.
I would stop there. I call it you want to have your nail go above the equator of the lesser troch. If the lesser troch becomes a circle, somewhere above the equator where you got it. And if you do enough retrograde nailing, you will see someone come in years later, broken at the top. I mean, that's mostly the geriatric patient who nailed when they're 80, and they're 85 and they come in at 89 and they have a femoral neck fracture. And just because they were now a femoral neck fracture, it's sort of unrelated to the nails, the one I've had. They don't really get transverse fractures at the tip of the nail. They come in with a displaced Garden 4. Great, I have to take the nail out, do a hemi.
Susan? Sorry.
One of the things that's really hard to get is to not have an extension deformity a little bit at the knee there. We all struggle with that. I think that might be a little bit extended there. There's so much comminution on that anterior cortex. And in my hands at least, sometimes dual plating as opposed to plate nail combo helps me to control that a little bit better.
Yes. And
One
you-
thing to consider.
Okay. You let them weight bear right away also with the dual plating?
I do not. I'm a big chicken.
Oh, okay.
I absolutely let them partial weight bear so that they can mobilize. And some of them probably just weight bear fully.
Okay.
But my instruction to them is like a 50%.
Okay. All right.
Yeah, if you can do weight bear to tolerance for transfers only, that's like they'll weight bear 4 times a day. At least they'll get out of bed, because if you say non-weight bearing, they'll never get out of bed.
Right. Yeah, they got to get out of bed, and they got to be able to do that with some degree of independence, because no one's going to lift them.
And partial equals full, right? In the geriatric
Yeah,
population.
right. Well,
partial
that's what I
equals
say. I
full.
totally recognize that, right?
I
But I
know.
tell them anyway.
Makes us feel
so,
better,
you know.
but they just kind of do what they need to do.
Okay. I mean, again, I think there are multiple ways to treat this. You could just do a plate. I mean, in this situation, definitely would do a dual plate rather than just a lateral plate. If I had to just do a plate construct. But again, look at the fracture location. Look at the stability of the implant and fracture also, as far as like if it's loosening in the bone implant interface. Know the patient's physiology. I think that's always important, and also surgeon experience. What are you comfortable with? If you don't do nail plating, you know that you're better with like dual plating, or if you want to do just distal femoral replacement, which I don't think is the right one in this situation, but do what is comfortable for you. I think that's important. In saying that, I want to continue on this topic. I have a 71-year-old female with a total knee arthroplasty, had it 30 years ago. She tripped, fell down, multiple comorbidities, diabetic, had DVTs, PEs on, anticoagulants, factor V laden, mutation, history of uterine and thyroid cancer. This is a closed injury. The only thing also with this patient from a physical exam standpoint had venous stasis changes. The distal 1/3 of the leg, and the BMI was beautiful, 55.14. And this is what she has. Ken?
Ooh, he's banged up. Is this 30 years old, you said?
30 years old. That's
Hey,
what he
tip
said.
your
It looks
cap
like
to
a newer
that.
implant.
Yeah,
'Cause
yeah.
That, to me, I thought that, I forgot the name of the
So-
company, but this looks something newer than
Did they make, looks like there's a box, right?
it's a box.
Okay. So I'm assuming you got a CT because it buys you time.
Got a CT. So, got a CT. Try to get as many views as possible here.
Man, she's big.
Big.
These wounds are dangerous on these big people because they just lay on them.
Just got something at the flange just so you can see
Yeah.
what's
Where?
going on there. So, what's the plan?
I'd fix her the same.
Fix it the same?
I probably have to do a nail plate. I don't love that procedure, but I think for this one's really distal. Either nail plate. I don't think I would dual plate her because of that venous stasis. You said that medial side's dangerous to me, opening that up. We try to avoid a wound. And I think she should be able to heal it. 30 years old, a long time. I don't even think you'll find the poly to exchange if you needed to exchange it.
Right. I agree. And I'll be honest with you, I put 30, but I'll be honest with you, I don't think she knew. There's no way that's
Yeah,
30
who knows?
years old.
Yeah,
Looks like
it was a great job, whoever did it.
Oh, yeah. Anybody else would fix? Anybody in the audience would do anything different? Well, I'll be honest with you. We went and fixed this thing. That was the plan. So, came in on a Thursday evening. One of my partners, trauma guy, called me on a Friday. I was getting on the plane. I was like, hey, what you gonna do? It's like, yeah, I would fix it too. I agree with you. So we went in there. What approach did you use, first and foremost, before I say anything? If you did this open, what would you use? You do a lateral approach? Would you do a midline approach? What would you do? Because he did a lateral approach, because he wanted to fix it. And there was a big void in the front. The thing was loose. What do we do next? Tesh, anything? Any thoughts?
Stop.
Stop.
If I have a loose implant, I can't fix that, okay?
Is
Washed
the-
out, put in bone cement, back to the wound. and
Yeah, is that
transfer.
implant totally debonded from there, or is it?
Totally debonded from
Yeah,
there.
I mean, you
Totally
gotta pack
debonded.
up, yeah.
So you pack it up, do you do anything? Do you put on an X-fix? Again, now you've created almost a controlled open injury, right? Granted that, it was closed, you opened to do some good work, but again, you've disrupted the soft tissue envelope that was caught holding everything together. And, okay, put some cement. Would you X-fix?
I probably would've.
Depends how unstable that thing. You can't
Yeah.
leave her slopping around, then she's gonna have like a, how you gonna know if her knee's even like located? She's so big. Like you'd have to give her, do something, like maybe lay a wad of antibiotic cement between the flange and the, where it's rocking
get
around
something
on you. Something that's just stick. But we're lucky because like the guys in the next room, we got tons of DFR guys that would just come in. So we usually put it on every consent. The possible,
Distal femoral
yeah,
replacement.
possible distal femoral
They're on
replacement.
the shelf, ready to go.
They're on the shelf, ready to go. Because, we had a big tumor presence there, so they're just like right there. It's like literally,
So if you're the trauma person and it's a Saturday, you're going to do this case because you know how to do the case.
yeah, would I do this one on Saturday? Probably not.
Okay.
Probably not. I don't look at this fracture the same as I do a hip and everything. I think I can like put her in a knee immobilizer and get her out of bed, if she can tolerate the pain.
Anybody do anything different?
I think for the audience, like, if you're not at a place where the joints guy's operating right next door, if I reach that point there, I would put him in an X-fix because I don't know when the joints guy's going to see her, and I don't want her to be unstable and causing more soft tissue trauma, vascular compromise, et cetera. So I would X-fix it at that point.
And you might need,
You got to be careful, yeah.
and you might have to, they might have to leave your facility, like what they do.
That's correct, yeah.
His facility, they'd stay there. My facility, they might, so I'd say, I'm just gonna put an immobilizer on, but if you're in a facility that they physically will have to leave and they go on a truck, maybe you have to put them in a frame. That's
I'm
gives
very
you,
schizophrenic, because my one facility, I'd walk next door, and the other facility, they have to go like 25 miles to
yeah, well, that's
get to
a, that's
somebody.
Yeah, I
a,
think your options are not stabilized. Like the outcome could be way worse than having like a stem, DFR you can bypass dang near anything. And you'd probably keep it close, right? You'd keep your pins kind of closer
Tight,
than you
yeah,
normally do.
tight.
Tight, yeah, tight.
Tight
on the,
or really far.
yeah,
right, if you needed
right.
2-point
I would put them
fixation.
tight though, because those heavy set ladies that,
They're really far.
yeah.
They've had people that fractured through nav pins that have large legs. So you put a big 5 or 6 pin femur up high,
Yeah.
and start the weight bear.
Oh, no.
no weight bearing.
No weight bearing, she's just going,
If you're doing DFR,
oh, oh, you mean after the frame is out, yeah.
you do your DFR, and
Yeah.
your pin is up,
Yeah.
for less retrope. I mean, like I said, they've had reports of navigation pins, extra navigation pins fracturing with weight bearing initiation post-op. So if you're going to X-fix this, which I would recommend, either you stay really close so you can fill it up with your stem and cement. I would not go way far.
And, luckily, kind of listen to you. The pins were close because the girth and the proximal part of the thigh, you would have needed like probably one of those pelvic size Chance pins just to get through, and for him to feel the bone probably wasn't best, but this is what we did. So again, we talk about periprosthetic distal femur fractures after, total knee replacements. The question is, do the classification systems really help you out? I don't know how much. I think from what the panelists said, I think it's really more descriptive. What they tell you, what the resident tells you, what the advanced practitioner tells you, but what you really see on the radiograph is what dictates what you're going to do in the operating room. And sometimes the CT scan may not even tell you what's going on. Again, there have been so many different classification systems, but nothing has really panned out to tell you that, I will do a DFR because this is classified 5Z or whatever it is. So again, I think it's just being able to make sure that you have everything in your armamentarium when you're trying to go take care of these fractures. And again, there have been some studies also looking at CT scans and how helpful they are in diagnosing loosening. And very rare. I think you probably get the same information from an x-ray, but again, it's very routine that we get CTs for these anyway. I know there was a paper out of the JOS by the guys out at Stanford kind of looking at trauma-trained people versus those who are joint arthroplasty fellowship trained, and then those who did a dual fellowship. And again, us as trauma, we want to fix these things right away, right? Those who are joint trained will try to do a DFR right away, and the people who are dual trained actually lean toward doing a DFR because, again, they had some sort of training with doing joints, so they knew from the elective practices how those patients would probably pan out. All that to say is, on the next Monday, I kind of did this, had a couple of cement regions, some areas of the screw holes where cement kind of extruded. I wasn't going to go posterior and dig that thing out, but that's what this lady ended up with. Have a weight bearing that's tolerated. Would anybody do anything different?
I mean, if she stayed at your institution, you could put her in a binder and she can sit for 2 or 3 days. That's the only thing different, I'd say. So I don't think you'd need the X-Fix, but DFR for loose implants indicated here. Looks good. And then I there was this whole DFR thing happening recently, and then I got a little fired up. So I called as many of my joint replacement colleagues as I could, and the people who revise things, and I asked them, are you converting any of my ORFs to DFRs? Are people falling apart and I'm not aware of it? And I couldn't find anybody. Like, so I'm fixing them and sort of getting it right. So this DFR idea to me was just trending a little bit too aggressive. I don't know. This one I'd agree with. This is a loose implant.
Yeah, that's what we found. We found when we looked up ours that the glory of the DFR, people walking out of the hospital, doesn't exist.
Yeah.
And the ORFs were doing equivalent, if not slightly less, revision rates at our place.
Yeah. I mean, it might not be 0, but the point is it's not 80% or something like that. It's not like a femoral neck fracture that you're pinning that fell apart within 3 months. It's different. You can fix it, get it right, they do okay.
Right. So again, benefits, you mobilize these patients earlier, probably shorter OR time depending, just kind of lopping that distal part off and putting these implants in. You just have to watch out for some of the complications, which are really bad. Extensive mechanism injuries, those things can kind of dislocate on you. Again, there's nothing worse than getting a periprosthetic joint infection in somebody that has a distal femoral replacement. So, and also these periprosthetic fractures can also occur. Saying that, when they looked at outcomes, probably the same when they compare retrograde intramedullary nailing versus plate fixation versus DFR. But again, the complications, even though they may be the same, some are probably a little bit worse, and there's no salvage from it. I know we have 1 minute, so 5 minutes. I'll make this real quick. Anybody have any questions? I'm just gonna run through this last one. 68-year-old male, alcoholic, but very nice dude. Status supposed to fall in the kitchen. Had some loss of consciousness, but again, no history of prior hip pain, multiple comorbidities, not on any anticoagulants, but has had other orthopedic surgeries, left tibia, shoulder, and also the contralateral hip. On physical exam, again, closed injury, not necessarily shortened, but stayed in the externally rotated position. Maybe in the high end of malnourishment, I guess. Albumin is somewhat in the low end, but total protein is not bad, but it's emaciated. BMI is about 16.53. This is what I got. Susan?
So, impacted femoral neck.
Okay.
There's maybe a touch of, it's not valgus impacted, let me put it that way. It's just neutrally impacted, maybe a touch of varus.
Okay.
So, it doesn't fit the classification of a valgus impacted that you would normally put cannulated screws. Maybe it's overkill, but to be honest, I might get a CAT scan.
Okay.
Take a little closer look, make sure there's no other fracture lines that I'm not really seeing that would affect my decision as to what to do next.
Awesome. Anybody else?
They get a CAT scan, yeah. Look at the axials, see what the angle, the true angle displacement is. You don't unfortunately have another hip to compare it to, but looks like he's an osteoporotic nightmare based on that right
Been
hip.
through it already, yeah.
His capacity to heal is pretty limited, just in the clinical scenario that you just described. He's a vascular path. You can see his femoral arteries showing up there. He's osteopenic. We could get the CAT scan. Is it going to change our management? We'll see. but, okay.
What you got? Does it change?
It's falling off the back.
Well, it's more displaced, it's posteriorly, right, falling off the back, and it's actually a shorter segment of head than I would have guessed from the original X-ray.
Okay.
So just bad and badder.
Bad.
Yeah.
Mitesh, anything?
No, I totally agree. I mean, the thing that you can't quite tell on that lateral is how much of that posterior tilt that was there, and you can see it a lot clearer here. I think it kind of forces you more and more towards thinking an arthroplasty solution for this patient.
Okay. Anybody do anything different? Well, here you go. There you go.
Boom.
Womp womp.
There you go.
Isn't trauma great?
It's
Yeah.
beautiful.
You can just do whatever you want. You just got to have a good reason for it, you know?
Fantastic. Any critiques?
So why did you, can I ask why you chose this then?
Well, the starting point's not subtrochanteric, so we got that going for us.
Yeah.
No, it's good. The screws are nicely flared on the lateral and everything like that.
Now, is that a good thing, though? That's the other thing.
Well, that's a good question, yeah.
Having it flared up, you know, when you look at the literature, for young patients, if you flare, you know, when you're doing these, it's not closed reduction, you're really just doing like, you know, screw fixation. You try to fill the canal on both AP, you know, coronal and sagittal planes, but at the same time, you know, if you do it all parallel, it's probably
Then it
better
can
for the
collapse
patient,
more.
right? Especially in the geriatric population. So something to be mindful of. And again, I remember, you know, when I first started, I would tell my residents still, hey, you know, why don't you just kind of spread it out? Because I want to make sure you get on the lateral, everything is hugging the anterior and posterior cortex, you know, making sure that you're just hugging that superior aspect of the neck on a coronal view. But maybe that's not the right thing. But
I got no problem with this. You want 3 screws acting like 3 screws. When they see like 3 centrally placed screws, that like acts like 1 big screw. So these are 3 screws acting like 3 screws.
Right.
Slightly divergent on that lateral. That's fine. I like it.
well, he did what he wanted to do. So this is 2 weeks.
Well, in other words, was he told not to put weight on it?
Oh, of course he was. But you know
Well,
he's
then-
going to do it.
You gotta let him put weight on
You
it.
got to put weight on it. Yeah, if you're going to do that, you got to have confidence. You either did. So, to be, since you're being critical or inviting us to be that, is this the wrong surgery done well? Sort of idea.
Yes, that's the question, right? That's the question.
Somebody did the wrong surgery really, really well. But here we are.
So again, it's one of those things where, you know, you want to look at that posterior angulation, right? They talk about the 20 degrees, even 10 degrees of anterior angulation is probably correlates with revision with these kind of cases. But in 5 months, you know, he started really complaining of pain. The guy walked on it, he was good. I mean, he drank a lot, so I don't know how much that numbed the pain, but he kept going. So 5 months in now,
I mean, look at his arteries on the CT scan. This guy's just not going to heal.
so that's what he ended up getting.
That looks nice.
Not cemented, huh?
Not cemented.
68-year-old alcoholic, non-compliant.
So again, how many was cement? Right? So again, that's
Who
the
likes
point.
who likes to snap off the greater troch when they put down the implant, like this guy?
So again, one of the things that you definitely want to be.
Contralateral fin.
Who likes to put the cable around the proximal femur to make sure they don't break the femur?
Contralateral film, you see THA with multiple cables, you know that this is going to be a problem.
Signs of a struggle.
Regardless of what we do, number 2, he's an alcoholic, and he's physiologically much older than 68 years of age. So hemiarthroplasty, cemented hemiarthroplasty, and this pathologic injury is something that should be considered as your primary surgery initially.
Right.
I mean, femoral neck fractures that are complete in the elderly population are not innocuous and should really, really be considered for arthroplasty rather than internal fixation. So, complete plus he was embarrassed and he had posterior angulation and had poor bone, BMI of 16. Usually they're 55, which is normal for you up in your area.
Right.
You know, just bone quality, underlying patient presentation. So.
And that's very important. I think, you know, when we talk about femoral neck fractures, you know, a lot of times, sometimes we'll go for the older patients, you usually do screws, try to stay away from, you know, using a DHS because of, you know, what complications can occur with those without seeing necrosis. But again, I think probably leaning towards doing some sort of arthroplasty is probably the best thing because it gets these patients up right away. I would definitely think about cementing. In some of these geriatric patients, that's very important. But in diagnosing these, again, something that the panel kind of alluded to, looking at the tilt, again, not just 20 degrees of posterior, but also 10 degrees of anterior tilt. CT scan, probably helpful, and especially if a lot of these fractures, because it kind of better delineates what the characteristics are. I like 3D recons also. You may actually see some sort of medial comminution that will tell you, you know what, let me err on the side of doing something from the arthroplasty standpoint. Again, screw trajectory may make a difference, but I think, you know, again, I don't like things being like one big lag screw like Matt kind of alluded to. But again, the configuration of your screws will kind of dictate what kind of complication you may have if the femoral neck kind of shortens in these patients. Again, 80 years old. Again, 80 is not 80. I was born 80 years ago. It's a 60-something-year-old that has multiple comorbidities, right? They fall into that category. Malnourishment. Again, these patients are not going to have great healing potential. Again, poor bone quality. That's why you need to cement these so that we don't end up doing a periprosthetic femur fracture real soon. As far as reoperation rates, more common with some of these cancellous screw fixation versus if you went ahead and did some sort of arthroplasty. But again, the hemiarthroplasty cases, cost effective, right? These patients, yes, they're getting out of bed, even though in fixation they get out of the operating room much faster, and you have them walk, and their length of stay is much less. In the long run, when you take into account that they may have some sort of revision, whether it's removal of screws or some sort of arthroplasty to salvage, they're probably cost effective to kind of do some sort of arthroplasty right away. So that's really about it. Any questions? Go ahead.
So when you're looking at those kind of borderline femoral neck fractures, you're okay with the posterior tilt being below 20 degrees. Does the Powell's angle, like the verticality of the fracture, ever kind of turn you away from cannulated screws? What concern the shear forces? Maybe considering like, if not arthroplasty, then like femoral neck system or something else?
Good question. Anybody would use anything else in a geriatric femoral neck fracture? I don't think the Powell's angle, I really don't use that when I'm thinking about the geriatric population. It's usually for the younger patients if I'm trying to fix them. But for the elderly population, I'll be honest with you, if there's any kind of displacement, I'm doing an arthroplasty. Would anybody use like some of the newer implants for any of these geriatric femoral neck fractures?
No. I've been using, I kind of think, just like we kind of been talking about, spreading those screws out and having them fill that space in the neck and the head and act more like 3 separate screws rather than one big screw. I'm pretty solid on keeping with the 3-screw technique right now, but I don't know if other people are having different experiences or think differently about it. It just feels like that fixation pattern will do better for you, especially for really poor bone centrally in that neck and head. If you put 1 screw in that poor bone centrally in the neck and head, it just doesn't seem to do what you want it to do.
Yeah, the FNS has been beautiful, I think, for the intermediate, you know, femoral neck fracture of a young person, because you get the dang reduction, you don't have to rip it apart with
The
your
rotation,
DHS anymore. And so that for me has been great. And we're starting to see them trickle in a little bit, the subtroch fractures from the FNS on the elderly.
Yep.
Where if you think about it, you're preached against putting that 3-screw construct. Don't put it below the lesser, right? Now you're putting 2 lock screws at or below the lesser, and that's just a recipe.
Yeah, really stiff construct right there.
Yeah, really stiff.
Yep.
Anybody using any kind of augments you think is warranted when you're doing cannulated screw fixation?
See, it seems like augments, then you should be doing a hemi, like the last case first type of thing, to me anyway.
Gotcha. Thank you, everybody.
Thank you.